All right, let's jump right in. We're going to tackle a really essential topic for any medical trainee, the differential for esophagitis. Understanding the different causes here is absolutely critical, not just for your exams, but for making the right call for your patients.
So let's start with this classic case. You'll see this kind of presentation over and over, both on boards and in the clinic. A young person, difficulty swallowing, but the real kicker here, the big clue we're going to circle back to, is that history of A to B, in this case asthma.
Okay, here's our game plan. We'll kick things off with the most common player, reflux esophagitis. Then we're going to get into its great imitator, eosinophilic esophagitis. After that, we'll cover direct injuries from things like pills. And finally, we'll bring it all home and show you how to tell these things apart. So let's start with the usual suspect, right? GERD-induced esophagitis. It is the most common cause by a long shot, but as you're about to see, it's not always as straightforward as you think.
So what's really going on here? Well, at its core, it's basically a plumbing problem. That valve at the bottom of the esophagus, the LES, it's just not doing its job properly. It's weak, it's floppy, and it allows stomach acid to splash back up where it doesn't belong, causing all that irritation.
Now, here's something that might surprise you. A huge chunk of patients with classic GERD symptoms, they get an endoscopy, and it looks totally normal. We call this non-erosive reflux disease, or NERD. It doesn't mean the reflux isn't real, it just means it hasn't caused visible damage yet. And that's exactly why that clinical tip is so key. If you take them off their PPIs for a few weeks, you have a much better shot at actually seeing any subtle damage that's there.
Okay, remember our patient from the beginning, the young guy with asthma who has trouble swallowing? Well, that brings us to the great imitator, a condition you absolutely have to have on your radar in this situation, eosinophilic esophagitis.
This is the big concept you need to grasp. Unlike GERD, which is a mechanical issue, EOE is an allergic disease. That analogy, asthma of the esophagus, is honestly perfect. It really drives home the idea that we're talking about inflammation triggered by allergens, usually something in their food.
And this right here, this is the classic illness script. This is the profile you should have burned into your brain when you see a younger patient, they've got a history of asthma, eczema, or other allergies, and their main complaint is that food gets stuck. Bam! Your EOE alarm bells should be ringing loud and clear.
And here it is, the magic number. If you remember one number from this whole talk, make it this one. The diagnosis isn't just about what we see with a scope, it's confirmed by the biopsy. The pathologist has to count more than 15 eosinophils in a single high-power field. 15. That's the number that seals the diagnosis.
Now, when you actually look inside with the endoscope, EOE can look really different from GERD. Instead of just some raw-looking erosions, you might see these really characteristic signs of chronic allergic inflammation. The esophagus can get these rings that make it look kind of like a windpipe. We call that trachealization. You might also see these long vertical lines called furrows and little white spots, which are actually clumps of eosinophils. So why do we care so much about telling these apart? Well, here it is. This is the whole ballgame. You can throw PPIs at a patient with EOE, and yeah, it might help a little, but it's not going to fix the root cause, that underlying allergic inflammation. They need totally different treatments, like swallowed steroids or changing their diet. If you get the diagnosis wrong, the patient just keeps suffering. Okay, let's switch gears and talk about two causes of esophagitis that are from a direct hit, a direct insult. For these, the diagnosis is made almost 100% by just taking a really good patient history. Yeah, for pill-induced esophagitis, you're basically a detective. The patient usually comes in with this sudden, sharp chest pain, and it hurts to swallow. You have to ask them, okay, what pills are you taking, and how are you taking them? The story is everything. And here's your most wanted list. Doxycycline is the classic bad guy here, along with things like NSAIDs and bisphosphonates. These pills are they're harsh. And if they get stuck and sit against the lining of the esophagus, they can cause a nasty chemical burn. The great news is this is so easy to prevent. This is the simple advice you give every patient, especially if they're taking one of those culprit medications. No dry swallowing a pill and then immediately lying down. Sit up, big glass of water, and stay upright for a bit. It makes a world of difference. Now, for a much more severe type of injury, caustic ingestion, this is a massive safety pearl, you have to know. There's this danger zone, this window of time after the injury where the esophageal tissue is super soft and fragile. If you try to stick a scope down there during that period, you're at a really high risk of poking a hole right through it. so timing is absolutely everything. All right, time to put it all together. This is where we synthesize all the key features that are going to help you tell one cause of esophagitis from another when you're faced with a patient. This table is pure gold. Seriously, it lays out the patterns so clearly. Look at the difference. For reflux, you're thinking heartburn in a patient of any age. For EOE, you're thinking food getting stuck in a young person with allergies. The scope findings are different, the biopsies are different, and most importantly, the treatments are completely different. This is a fantastic review slide. And let's end with a look to the future. Since we know EOE is an immune disease, it's opened the door for some really cool targeted biologic therapies. Things like dupilumab, which actually blocks specific inflammatory signals like IL-4 and IL-13. This is where the field is heading, away from just general steroids and towards true precision medicine for this condition. Pretty cool stuff.